Great. Hi, everyone, and thanks for the invitation to David and colleagues to give this talk. The work that I'm going to be talking about here, which is basically how the public understand health inequalities and how that compares to what researchers think needs to happen to tackle health inequalities, originally stems out of a conversation with David and Jerry and others about the kind of our lack of engagement very often with members of the public on discussing health inequalities. So there have been lots of efforts over the years to tackle health inequalities, or to think about how we tackle about it in research and policy terms. Surprisingly little efforts to engage the public in those discussions. Just to give you a kind of outline, I'm going to briefly go over the kinds of policy responses to health inequalities that researchers have been promoting in the UK, which has already come out from Jerry's talk in particular. And then I'm going to focus on how that compares to public understandings of health inequalities. And you can look at public understandings, obviously, in a number of different ways. So first of all, I'm going to give a brief summary of what the existing literature says about that, particularly the kind of in-depth sociological literature. Jerry was drawing on some of that. Then I'm going to talk briefly about the results of a national survey we conducted last year, and then on the results of some citizens' juries. I'll explain a bit more about what citizens' juries are, but effectively they're kind of very in-depth focus groups that go on for 2 days, where the people involved get a much more of a chance to hear about different perspectives on health inequalities and to see some of the research evidence. And there's a wider team that I'm working with, so I just want to acknowledge everyone there, and the research was funded by the Leverhulme Trust. So I've used this diagram a lot in talks over the years, and the key point that I've been making for a long time is that I think in public health we're often focused very much on how we can improve the evidence so that we better understand what's causing particular health problems and what might be done to reduce those health issues. If you take a more political science perspective, which Jeff just demonstrated very well in his talk, so Jeff has a political science background, you focus on very different things. You take a very different starting point often. So you're focusing much more on how different interests are trying to influence those policy debates, but also what the public think about issues and how they might influence that, and how public views are represented through the media and so on. So my argument here is not that we want to forget about the evidence, of course we don't, but that we need to think about how these two different parts of the system kind of come together much more, how we might bring them together. And I think in recent years, there has been more acknowledgement in health inequalities of the need to do this. So even people at ICS, quite traditional scientists like Johan Mackenbach, have called for more advocacy. So Mackenbach, reflecting on the failure of English efforts to substantially reduce health inequalities, kind of said, looking to the future, we need more advocacy to make sure that elected governments have a democratic mandate to make the necessary policy changes. Reducing health inequalities requires large-scale policy change in many fields, and this change will have to be articulated in political party programs. He doesn't make very clear that who is going to be leading this kind of advocacy work, and I think there are big questions around health inequalities because there aren't any large NGOs for whom health inequalities is their core issue, although lots of NGOs have an interest in it. But we have seen efforts by researchers in the field, in public sector and academia, to start kind of thinking more about public conversations on health inequalities. I particularly like these two examples. So the one on the left is Claire Bamborough's public health league table that kind of takes football league tables as its basis for inspiration. Could you just raise your hand if you recognise that public health league table? Okay, so it didn't get as wide a reach as I was thinking it might have done. But I think it was really successful in some ways because it got picked up by the Daily Mail, and then as part of the piece in the Daily Mail and their online website, they actually had Claire talking about social determinants of health and health inequalities. So that was quite a big win. And Jerry's map of Glasgow's transport system showing years of life lost. These kind of things are obviously really creative, innovative ways of explaining the extent of health inequalities between areas. But in terms of thinking about what are the actual policy responses that health inequalities researchers have been promoting, I mean, Jerry gave a kind of summary, and we've seen this diagram many times, probably this rainbow model of the social determinants of health. The key point I want to say here is that whilst there's a lot of consensus in health inequalities research about the kind of all of these different factors and different layers playing a role in health inequalities, this doesn't translate easily into clear policy recommendations. So when you get a group of researchers together who kind of come at this research issue from different angles, and you ask them to review the evidence and make policy recommendations, they often come up with quite broad goals. So these are the 6 policy objectives from the Marmot Review, the 2010 Marmot Review. I'm not going to read them all out, but the point here that I want to make is that these are not really policy objectives, I would say. They're very broad goals that we might all buy into, but they don't really give much specific guidance on what policymakers could do to tackle health inequalities. I mean, there is a bit more detail in the report, but if you looked at what would need to happen to achieve policy change from a kind of examples of where we've had success, there's been much more effort to get very clear consensus around a small number of policy-specific goals, and we haven't yet had that in health inequalities. Although the recent launch by the Scottish branch of the Faculty of Public Health, I think, is starting to move in the right direction on that. So I wanted to push researchers a bit more on that. So I conducted this online survey of health inequalities researchers to ask them very specifically what they thought would work to reduce health inequalities. I'm not going to go into the detail of this survey here, although it was interesting that when I asked people to answer based on the strength of the evidence or based on their personal expertise, their answers varied quite a lot. But the key point here, reflecting Jerry's presentation, is that the top 5 policy proposals for reducing health inequalities tend to be basically not health policies. They're about the redistribution of wealth and improving the environments in which people live. But they're very often related to income, so income and taxation. And this is difficult for public health as a community because obviously that involves policy levers over which we don't necessarily have that much control. So then what I want to talk about is how those kind of researcher suggestions on what needs to happen to reduce health inequalities relates to what the public think about health inequalities. So I undertook this thing called a metaethnography, which is basically a literature review, but focusing on in-depth sociological research with people, asking them what they think is the relationship between deprivation and health inequalities. And despite the massive health inequalities research that we've had over the last few decades, there's very little research that takes this kind of focus. So we only identified 17 studies across 20 publications. So very few indeed. There's a few more that use surveys, but we were focusing on the kind of sociological ones. And we didn't identify any study that asked people what they thought the kind of policy interventions to tackle health inequalities should be, or what they thought about any of the potential options on the table. As Jerry's already kind of indicated, people who have experienced socioeconomic disadvantage have a very good understanding of how living in that context and working in that context can impact on your health. So all of the studies demonstrate that people living in those circumstances have a good understanding of the social determinants of health and these pathways. So to try and kind of bring this together, I know this next slide is a really bad diagram, but basically, what I tried to do was each study I tried to draw a little diagram of all the different things that were being highlighted and how they were connected, and then I tried to merge them all together. But I mean, I think this diagram is useful in showing that people have very complex understandings. They see lots of interaction between lots of different factors, all of which can be mapped onto that social determinants of health model. This is a more kind of simplified version of that, and it's basically showing that people have a very good understanding that material structural factors have a really important impact on their health, and those often operate via psychosocial pathways, and lifestyle behavioural kind of routes are given generally much less focus in people's own accounts. As Jerry also indicated, the thing that comes out very strongly across all the studies is the importance of employment, particularly employment at a kind of community level. So this is a quotation from some research that was done in the Welsh Valleys talking about that. So this participant says, well, the first thing to go was the mines, but that was okay after a while. It was devastating for the miners, but that was okay really because then some of them could get work here in the steelworks. Some people moved away, but a lot of them came back as well. A lot of the miners came back, and the second link in the chain was British Steel. When it was announced that it was closing, and to me that was the death knell in the town, and everybody stood still, oh my God. And it was just like, if that chain was broken and it was flung away, they just didn't know what to do, none of us really. And as I say, really consistent across different studies that have been done in different parts of the UK. Also, people, more recently, the kind of work that people are able to get leads to this kind of no-pay, low-pay cycle, often very poor quality. The qualitative research is suggesting employers really aren't even following the law on the kind of basic provisions that they're supposed to give people, and placing people in a really precarious position where they're constantly entering and re-entering and leaving the labour market in poor conditions. And then the consistency within which unhealthy commodities were described, to me, was really striking. So whether it was drugs and alcohol, smoking, or unhealthy diet, people consistently described it as something to sort of distract you from the social reality of the kind of hardship of your life. So treats, and people were aware of their health consequences, but there were things to kind of take their mind off things. So I think there's a bit of a paradox here, because while the public, and particularly those who've experienced socioeconomic disadvantage, provide really sophisticated accounts of how these factors impact on their health, they're also reluctant, it seems, from both surveys and interview data, to explicitly acknowledge health inequalities between their areas and other areas. So why would that be? And I think from the research that's already been done, and it's probably fairly commonsensical too, it's partly about an attempt to resist the stigma of poor health and poverty and the shame associated with that, and partly about asserting a sense of control, a sense of, well, despite this, I've got some control over my health and the health of my family and so on. I think otherwise it's quite disempowering to acknowledge health inequalities. So that means we've got to think really carefully about the impact of public engagement efforts around health inequalities. And this comes from the Valerie McKenzie and colleague paper that Jerry was also quoting from. So this is someone reflecting on picking up the paper and seeing a story on health inequalities. So nearly every day I'm picking this paper up and I'm reading about the life expectancy with me compared to maybe staying down in London. They're absolutely kicking you in every way they can, like. And if you're in a poor area, you'll always be in a poor area. Nobody's going to try and help you out. But if you're in an affluent area, to hell with the rest. So with apologies for my non-Scottish accent for reading that lovely quote there. I think it shows just how careful we need to be in thinking about public engagement efforts, because if we're just drawing people's attention to the problem, we have to think carefully about who our audience is there and whether there are potentially negative impacts on other audiences. So then I'm going to say a little bit about a national survey. So we conducted this national survey. We asked people a lot of questions, both about what they thought about the extent of health inequalities, what impacts on their own health, and what they thought about potential policy responses. The results suggest that around 70% of people say that they're aware that richer people live longer. But when you kind of bring it down to the specific causes of health inequalities and premature mortality, most people don't seem to think that poorer people are more likely to experience key non-communicable diseases such as heart disease and cancer, mental health, or accidents. And I think that's quite surprising given how much policy and media focus has been on health inequalities over the last few decades. And the results in that respect are almost identical to results done in a survey in 1997, which is obviously having a big policy focus on this. So that suggests that public recognition of health inequalities has not increased since 1997. It also suggested that healthcare is the key, that most people think healthcare is a key solution to health inequalities, which is obviously something that we're keen to move away from, but I think it's very difficult when the NHS is held so dearly, rightly so, to so many people. But when you ask people about what influences their own health, the answers are more mixed, and healthcare doesn't come out top for either positive factors impacting on physical health or negative, and for mental health, that difference is even more striking. And then the other finding that I thought was really interesting was that most people supported all of the research, so the majority of people answering the survey supported all of the research-informed policy proposals, including in the survey, even ones that I hadn't expected that they would. And the interviews that I'd done with policymakers and researchers suggested generally people weren't expecting that. So things like increasing the minimum wage and introducing higher taxes for richer people. So then the third approach we took to looking at this issue was, we ran these citizens' juries, which, as I say, they're kind of like in-depth focus groups, but the jury members, it's a stratified sample to try and represent people with different backgrounds, different genders and different age groups and so on. We ran them in Glasgow, Manchester and Liverpool in July last year, and the Glasgow one was here in this building. So we aimed for 20 in each group, and we got 17 in Manchester, 19 in Liverpool, 20 in Glasgow. And what we did was we asked participants to complete the same questionnaire, which was the one we'd used in the national survey, at the beginning, so before they'd heard anything about the health inequalities evidence, in the midpoint at the end of day one, and then at the end of day two, when they'd heard from a range of different audiences, different kind of experts. And the results of this suggest that this kind of approach to discussing health inequalities increased participants' kind of willingness to openly acknowledge health inequalities and their associated sense of unfairness. And it also showed that after hearing about various different evidence, and I should say that they did hear about evidence from a range of different perspectives, including from NHS Scotland, promoting a more kind of behaviouralist approach to some extent, their support generally increased for redistributive policy responses, both individually but much more noticeably when they were collectively voting. So this is comparing their first choice policy response, first choice policy for reducing health inequalities, pre the citizens' jury and then at the end. And you can see support for spending more money on the NHS goes down, and then it's kind of spread across a range of different factors. But support for increasing taxes for rich people as a response to health inequalities is one of the ones that increases, for example. When we asked people to engage in collective voting, and they were doing this in ways, I think it's important to say, so the way that they did it was all of the policy proposals had a different number on them, and they wrote the number on little dots. So it was still done kind of privately, but it was done as a group, but other people couldn't necessarily see which choices you were making. So that's just a photo of the voting, and we did several rounds, and we discussed it and went back, and they were allowed to make their own suggestions. So when they'd made their own suggestions and we'd had the several rounds, these were the top proposals that came out in Glasgow, Manchester and Liverpool. I'm not going to try and read them all out, but I mean, I do think it's striking that not many of these policy proposals are traditional health policy proposals. A lot of them are about redistributing wealth and economic policies, even though I should add again, that wasn't the only evidence that they'd heard, so that wasn't the only viewpoint that they'd heard. But yes, the spending more money on the NHS persisted, particularly in Liverpool and Manchester, but most of the policies that were proposed were around economic policies, and where they came up with their own proposals themselves, those were often also economic proposals, so things like closing corporate tax loopholes. So the preliminary conclusions, and again, like many of the other findings that have been discussed here today. We're just in the middle of analysing this data, so it is very preliminary. But I think we can say there's been increasing recognition amongst health inequalities researchers in the last decade or so that efforts to produce evidence-based policy, promote evidence-based policy are kind of based on a flawed, technocratic, elitist approach to policy making. So if we want to get better at impacting on policy, then we need to think about all those other factors that are impacting on policy decision making, and that includes having more public engagement. Our initial approaches to doing this, so I think, have been very creative and are to be applauded. But I think we've tended to focus on outward-facing work, disseminating information, raising awareness about the extent of the problem. We've done less kind of focus on having a discussion around policy solutions, less listening to communities and seeing what they think about these issues. I think this is problematic because since the research evidence suggests that this approach, well, A, it doesn't seem to have increased explicit public recognition of health inequalities based on the survey evidence. But secondly, more importantly, I think people who experience socioeconomic disadvantage already have a good understanding of this, but they're reluctant to acknowledge it, not because of a lack of understanding, because that kind of acknowledgement is explicitly disempowering. So I think in that context, it's really important for us to think about ways in which we do public engagement around health inequalities, which links a discussion about the extent of health inequalities and the causes of health inequalities with a public discussion about what the potential solutions to that might be. I think the work that we did kind of using a deliberative approach, these citizens' juries, demonstrated that using that kind of approach with participants to discuss health inequalities seems to increase people's willingness to acknowledge the problem of health inequalities, their sense that health inequalities are unfair, and their support for research-informed policy responses, although this kind of over-expectation, I would say, of the role that the NHS might play in that remains. Okay, thanks very much.